Good morning, friends. I'm Amita Mahajan. I'm a senior consultant in Pediatric Hematology and Oncology at Apollo Hospitals, Delhi. Over the next few minutes, I will discuss ITP, specifically focusing on what we have learned new about its pathophysiology and management in the recent years. You will all agree that ITP is fairly commonly encountered in clinical practice, and though it's a benign condition, it is quite frightening for parents to see a child covered in bruises over a short period of time, and sometimes the numbers can frighten the treating physicians as well. There is often absence of identifiable precipitates, and it comes really as a bolt from the blue. And what I'm going to cover really is about diagnosis and management over the next few slides. So what have we learned new over the last few years? Well, we have better understanding about the pathophysiology of this condition. There has been an effort to standardize the terminology used. For example, what we mean by acute and chronic ITP or severe ITP was subject to interpretation depending on how we were using it, but this is now being standardized. There are also clearer treatment guidelines, which is very useful for the treating physician. In addition, there have been some novel therapeutic strategies which have been introduced even in the pediatric age group. We all know that the primary pathology in ITP is the development of autoantibodies, which remains central to its pathogenesis. The major target for autoantibodies is platelet membrane glycoprotein GB2B3A, but in addition, there are other mechanisms at play. So though it is now evident that decreased platelet production also plays an important role, and ITP is not merely a function of antibody-mediated platelet destruction. We also now understand that T cells, in addition to the B cells, are actively involved in cytotoxicity and platelet destruction, and this has come from the information that T regulatory cells are required for induction and maintenance of peripheral self-tolerance, and they are both reduced both in number and function in the vast majority of patients with ITP. The pathogenetic process in ITP is a continuous loop in which B cells produce antiplatelet autoantibodies, splenic macrophages phagocytose antibody-coated platelets, and CD4 positive T cells exert their helper activity in this pathogenic process. This cartoon depicts the complex interplay between T and B cells and how platelet destruction is brought about in an individual child with ITP. With regard to terminology and its standardization, there has been work from the International Working Group, and this work has been published as the Vicenza guidelines, which were published in 2008, which have led to clarification in guidelines. The first thing it has done is remove the term idiopathic, because we now know enough about the pathophysiology to label it as immune thrombocytopenic purpura. The threshold for diagnosis has also been clearly laid down that to diagnose ITP, we must have a platelet count of 1 lakh or less. And we must also define whether we are dealing with primary or secondary ITP, because the management needs to be based on this basis. What is newly diagnosed ITP? So ITP which has been diagnosed in previous 3 months, and this term has essentially replaced acute ITP, because when we see a newly diagnosed child, we do not know if he has been symptomatic for just the last few days or when did the exact disease onset begin. So up to 3 months is classified as newly diagnosed. When symptomatology has persisted between 3 to 12 months, it's labeled as persistent ITP. And chronic ITP term is only used when symptomatology or no thrombocytopenia has persisted beyond 12 months. What is severe ITP? This is used to define bleeding symptoms sufficient to mandate treatment. And usually it would mean a very low platelet count, a platelet count of less than 10,000, because above that, patients may largely be symptomatic only with bruising. The response criteria have also been clearly defined in these guidelines. So complete response to any modality or spontaneously is defined as achieving a platelet count above 100,000 Response is defined as achieving a platelet count between 30,000 to 100,000 or doubling of what was the baseline platelet count. No response is defined as platelet count persisting less than 30,000 or less than twice the baseline count. And refractory ITP is used when the patient has been refractory to splenectomy or relapsed with ITP following splenectomy. I will now focus on the management because that is what essentially would be useful for all of you. And what are the key management issues in managing a child with ITP? Firstly, with regards to the bone marrow, is it essential in every child to do? So should we do one, or can we manage a child without doing a bone marrow? Do we even need to treat, or can we manage these children without any active treatment? How extensively to investigate? What should be our first line therapy, or what should be our second line therapy, and who indeed should be an appropriate candidate for splenectomy? And I'll try to cover these issues over the next few minutes. A major adjunct to management has come from these guidelines published by the American Society of Hematology. They initially published a landmark guidance paper in 1996, but this has most recently been revised in 2011, and I would recommend this landmark document to you because this very clearly in a detailed manner tells how to manage these patients, and these guidelines are there both for children and adults. So in regards to bone marrow, our previous recommendation had been that all infants and all children over 10 years of age should undergo a bone marrow examination. In addition, any child who is contemplated to be treated with steroids should undergo bone marrow, primarily so that we do not miss the very occasional case of acute leukemia who may present with isolated thrombocytopenia at the onset. But it is now being highlighted that careful history and examination in peripheral smear remain the key to diagnosis, and the emphasis on bone marrow has decreased somehow. However, a bone marrow should be considered if there are any atypical features such as fever, bone pain, adenopathy, organomegaly, or any other abnormality on the CBC. But it can be omitted if one can ensure careful examination of the peripheral smear and regular follow-up. And where we are limited in our setting is with regards to regular follow-up, because we may see the patient only once and this patient may not subsequently come back to us. So we must interpret these guidelines or adapt them for our own scenario. So our recommendation would be that if there are any concerns regarding the diagnosis whatsoever, the child must undergo a bone marrow examination. If you are not sure that the child will come back regularly for follow-up, it may again be a unique opportunity to do a bone marrow so that no child with acute leukemia or myelodysplastic syndrome is missed and wrongly treated or managed as ITP. Should we do antiplatelet antibodies? This is of course an antibody-mediated disease largely, so an antibody assay should be able to diagnose and hope maybe monitor us. But no, that is not the case. The antiplatelet antibodies have very poor specificity and sensitivity in this condition. They offer no prognostic value whatsoever and therefore are neither routinely indicated or recommended in this condition. Should every child presenting with ITP be tested for ANA or APLA? ANA is positive in up to 30% children with ITP and lupus anticoagulant in 20 to 30%. It is currently not routinely recommended to do this test for all children, but it may be considered individually, especially in older children, girls specifically, with chronic or persistent ITP, and that is the setting in which I would most often recommend this test. What about routine testing for H. pylori? There has been some published data on association of ITP with H. pylori, and this has also been further substantiated by complete resolution of ITP when H. pylori has been eradicated with therapy. However, the current guidelines do not recommend to do this test routinely for all children, and it is only to be done if it is indicated based on clinical grounds. What about HCV and HIV? We know that both these conditions can lead to secondary ITP, and the current guidelines mandate that all adults who present with ITP should be screened with HIV and HCV because they have a very much higher incidence of secondary ITP. In children, the current guidelines recommend that we should decide this on the basis of individual child, and we would normally recommend it for patients with persistent or chronic ITP. Also, it is recommended in cases where we are contemplating therapy with rituximab, to which I will allude to a little later in this presentation, because rituximab is fairly immunosuppressive and it may lead to reactivation of latent hepatitis B or C condition. Coming finally to the treatment of the individual child. So the big dilemma is to treat or not to treat. We know for a fact that there is very low incidence of serious bleeding episodes in children, and treatment does not really alter the overall clinical course. And there is abundant data to substantiate this. Treatment also does not reduce the chances of an individual child developing chronic ITP. In a study which pooled data from 12 series, the patients in remission at 6 months without treatment were to the tune of 83% and with treatment 76%. There may be some bias for patients presenting with more severe disease or prolonged disease to be treated, but virtually there was no statistical difference at the end of 6 months whether we treat or do not treat. So the current guidelines recommend that we should treat a patient if they are symptomatic. Again, the Intercontinental ITP Registry, which has prospectively looked at over 2,500 children presenting with newly diagnosed ITP, their survey revealed that 38% did not receive any treatment, 29% received immunoglobulin as frontline therapy, 33% patients received corticosteroids, and 7% received both of these above modalities. This is a little while ago, and anti-D was not a routine part of management at that time, so the study did not really look at that. The registry showed that if we looked at platelet count of 150,000 at 6 months, the proportion of patients who never received any treatment who achieved this number was 68%, which wasn't really much different from patients who received treatment with either immunoglobulins or corticosteroids. The risk of IC bleed is the concern for which we all are concerned about, and we require, we recommend treatment primarily to prevent this eventuality. And this study and many other studies shows, as is alluded in the slide, that the incidence of severe bleeding or severe IC bleeding is indeed extremely low, led to the tune of less than 0.2%. There is also no relationship between management and the development of severe hemorrhage, and the decision to hold treatment requires detailed discussion with the family, because if they are extremely anxious, they will eventually end up taking treatment for somewhere. So if we were to pursue the path of no treatment, we need to counsel the family, we need to share what we know about the low incidence of intrapenial or other severe bleeds in this condition. Only then we can convince them to opt for no treatment option. So what really are indications for treatment as guidelines stand today? So any bleeding symptoms, and this does not allude to bruising, this means epistaxis, which is difficult to control, persistent gum bleeding, or bleeding from any other side. If follow-up cannot be assured, because then we would not be able to assist the patient in time. If there are social concerns in terms of poor access to care, and if there are lifestyle issues that the patient is engaged in activities which increase the risk of bleeds, such as contact sports or some other concerns like these. What should be our first line therapy? At the moment, the 3 options available to us are steroids, IV immunoglobulin, and IV NTT, and the response rate to each of them is identical, so the treatment is dictated really by depending on whether the patient is hospitalized or not, and primarily in our setting because of cost. If we were to choose corticosteroids, which is the cheapest option, if we can use an oral option, it would be to the tune of 1 to 4 milligram per kg. Again, there are different studies at different doses. So 1 to 4 mg per kg usually for 4 weeks and then tapered over the subsequent 2 weeks. Or we could use the parenteral route, which is 30 mg per kg for 3 to 5 days. The response rate to both of these is virtually identical and is to the tune of 75 to 80%. If we choose to use IVIG, the traditional dose has been 1 mg per kg for 2 subsequent doses, but recent data has shown that a single dose of 0.8 mg per kg, which is much more cost effective, is as efficacious. The only advantage of using IVIG versus steroids is that the response is earlier by 12 to 24 hours. And again, if there are any concerns about the underlying diagnosis and the bone marrow is not feasible, IVIG does not change the bone marrow picture and may be an option in that setting. The response rate is again to the tune of 75 to 80%. IVIG can only function in rhesus positive, non-splenectomized patients, and the current recommendation recommends single dose 75 microgram per kg, but if the hemoglobin is less than 10, then to give this in 2 divided doses over 2 subsequent days. And it is contraindicated if there is any evidence of hemolysis, because IVIG essentially works by directing the antibody-mediated destruction to red cells rather than platelets. And again, the response rate documented has been up to 75%. If the patient requires treatment and fails frontline therapy, what are our options for second-line treatment? It depends on what has been used upfront, and we could use one of the other options as second-line treatment. But recently, there is data with rituximab, and that it can get us into remission after they have failed frontline therapy. Also, high-dose dexamethasone for 4 doses every 4 weeks has been used in this setting as second-line therapy with fairly good results. With regards to rituximab, it is an anti-CD20 monoclonal antibody, and the recommended dose is weekly dose for 4 weeks. The dose in which it is used for non-Hodgkin lymphoma is 375 mg per square meter, and this was the dose which was initially used in ITP, but recent data shows that a dose of 100 mg per square meter, or in fact just 100 mg in an adult, it gives the same response as the higher dose. So this is the dose that is the lower dose is the more frequently used option currently. The response rate is about 25 to 63%. What about platelet transfusions? When a patient presents with extensive bruising and platelet counts of 2000, it is always tempting to contemplate platelet transfusion, but platelet count alone should never suffice as an indication for transfusion. The only indication currently for platelet transfusion in this setting is acute uncontrolled bleeding, and even in that setting it will work only when we have given some other therapy concomitantly, which can reduce the platelet antibody-mediated destruction. What about chronic ITP, which is even more challenging than acute ITP? These tend to be older children who continue to be symptomatic. Again, the platelet count alone should not be our deciding factor for management or treatment, and treatment is warranted only if the patient is significantly symptomatic in the form of bleeding from any side, menorrhagia, and if the child wants to pursue a lifestyle such as active participation in athletics, then one must contemplate treatment for these patients. So what are currently available treatment options for chronic ITP? Again, corticosteroids, IVIG and rituximab are available. One may need to consider splenectomy, though in the pediatric age group it is our effort to delay or not do splenectomy as far as possible. There are other options as well, such as cyclosporin, azathioprine, and mycophenolate mofetil, as well as vincristine, which has been tried in this setting. So there is no standard second-line therapy as we stand today. Treatment needs to be individualized for every single child based on their requirement, based on their access to care and affordability. So who should we reserve splenectomy for? It is the most effective therapy for chronic ITP, but like I mentioned earlier, we try to avoid this as far as possible. But it may be considered in children with chronic or persistent ITP with significant bleeding, lack of responsiveness, or intolerance to other strategies. And if we were to at all consider it, we would prefer the laparoscopic route, but also requesting the surgeon to look at spleniculæ, because the commonest reason for failure of splenectomy is the presence of accessory spleens which may have been missed at the time of surgery. What about the thrombopoietic agents in ITP? There are 2 new agents that have been introduced which are both known to be effective in ITP. Like I alluded to earlier, that though increased destruction is the major pathogenetic mechanism, there is now evidence of decreased production, and this plays an important role in the pathogenesis of this condition. So there has been a concerted effort to develop safe and efficacious thrombopoietic agents. The first generation had a number of adverse events, following which they were actually withdrawn for this indication. We currently have two agents with us, romiplastin, which is given as a subcutaneous injection, and eltrombopac, which is available an oral drug. Romiplastin is a thrombopoietin mimetic peptide body, which is given weekly subcutaneously. It has a reasonable response rate in non-splenectomized patients, and it is even effective in splenectomized patients. The adverse events are not markedly increased and are predominantly headache and other things. There were concerns about myelofibrosis in the bone marrow, and that has been largely shown to be hypothetical, as patients can receive this. In children, however, weekly injections are not the preferred modality, and it is not currently available in India as well. What is available to us is eltrombopac, which is the only orally available molecule currently, which needs to be given daily and has shown to be efficacious and reasonably well tolerated in the pediatric population as well. The only concern is its high cost, and that also prevents us from misusing this drug. So it is really useful for patients who are post-splenectomy, still symptomatic with severe bleeding, and they may need to receive this drug. The effect only lasts as long as that drug is given, which is its major limitation. So the response is transient, and only till medications are ongoing. The costs continue to be prohibitive, and we have concerns regarding thromboembolic events and increased reticulin in the marrow, as long-term data is still awaited on these two drugs, but they are options for very difficult to manage patients. So in children, the role is likely to be very limited, but it can be useful in specific situations wherein perhaps for a surgical procedure we need to increase the platelet count prior to the procedure, and we specifically use it in that setting. So what are some of the novel approaches to ITP treatment that are currently being evaluated? Inhibition of T and B lymphocyte crosstalk, inhibition of CD40 signaling cells with some specific agents, and expression of upregulation of T regulatory lymphocytes, and these are approaches that currently in clinical trials are being evaluated. Specifically in adults, where managing patients is even more challenging. How do we manage secondary ITP? So with regards to HIV-related ITP, again our treatment options are primarily to treat with retroviral therapy, but steroids, IVIG, IVATD may be indicated for some patients. For hepatitis C-related ITP, it will essentially be antiviral treatment, and if we needed to treat, otherwise IVIG would be the mainstay. For H. pylori-related ITP, it will be eradication therapy. So summarizing finally, ITP is a relatively benign condition. No treatment is the definite option both for newly diagnosed ITP, persistent and chronic ITP. Platelet transfusion is hardly ever indicated, and treatment should be warranted by patient's symptoms. Finally, the management needs to be individualized for each child depending on his or her symptoms, their access to care, and their understanding of this condition. Thank you so much for your attention.